Well, as a means of disclosure, I am not Mustafa Biskaya. I'm taller. As you may have heard, Dr. Biskaya was unable to join us today, and so I was going to be outside in the sun and the beautiful weather, but thought I'd join you all. Secondary prevention, and I'm going to focus on some recent antithrombotic trials. When we look at stroke reduction and risk factor reduction and stroke prevention, there are three major realms or three major areas that we look at. Pat McBride will be here later, and we'll talk about hypertension and perhaps other aspects of aggressive risk factor management in our patients. I'm going to spend a little time on antithrombotic strategies. Later, Dr. Jensen will also, probably half of his formal comments on an antithrombotic strategy. And then there are surgical interventions when feasible, although we love to see patients in the surgery clinic, in the neurosurgery clinic, in the vascular clinic, and we love to talk about surgical procedures. They actually end up being a very small percentage of what we do for stroke treatment and stroke prevention. With the antithrombotic strategies as a means of introduction, these will help limit recurring events. So a stroke patient on the right antithrombotic strategy will likely have less recurrent stroke, perhaps less heart attack, perhaps fewer clots in their legs or clots in their lungs. Often, because of antithrombotic strategies, we're going to talk about mechanism-specific therapy, and I'll try to elucidate that. And often this is, unfortunately, although everyone that knows me knows that I can go on and on and on about this blood thinner or that blood thinner, having started research in the lab and with blood thinners in the 70s, before some of you were born by a long shot, but perhaps. This is only one aspect of the overall management. So again, today's talks started with Dr. Satins, and the rest of the talks are going to try to piece together what we do as a comprehensive stroke unit and a comprehensive stroke program. So this is just one small aspect of the whole scenario. The recent patient, 58-year-old man, atrial fibrillation, presented with acute, mild difficulty communicating, no other symptoms. He had a known allergy to warfarin. His atrial fibrillation was well rate controlled. He was on a little aspirin, and all evidence at the bedside and testing pointed to embolism from his heart to the left side of his brain. Dr. Satin talked about localization to a certain point. In this situation, we have on both of your lefts, we have CAT scans. On both of your rights, a CT perfusion image, and the positive arrow, at least there should be one. It's a nice red arrow that I can see. There's a small area of acute ischemic change on the perfusion map image corresponding, that's a mean transit time, but again, it's a physiologic area of acute ischemic injury corresponding to his mild aphasia. So we felt this was embolic from his heart. We took pictures of his arteries, and they're all quite normal. The carotid arteries in a couple different views. This is with CT angiography. With CT angiography, the middle cerebral complex. And again, the left middle cerebral, and this guy with the arrow, the left carotid, there's a tiny bit of plaque, perhaps, a little tiny plaque, but we still felt it was from the patient's heart. So then what antithrombotic option should be considered for this cardioembolic stroke, as this particular patient cannot take dose-adjusted warfarin? In the recent literature, especially the one that's still in press, it's not as of this week, maybe it'll be in next week's New England Journal of Medicine. A few years ago in Lancet, Active W, and then more recently Active A, and these are studies in the atrial fibrillation population. Active W looked at 6,000 plus patients with known atrial fibrillation. All had one or more extra risk factors for stroke. So they may have had prior stroke or prior TIAs and their atrial fibrillation, for example. Even if they had already been on warfarin, they were randomly assigned either to stay on warfarin or to go on a combination of, as you see, low-dose aspirin plus clopidogrel therapy.